If your doctor recently told you your blood pressure looks perfect and you walked out feeling relieved, stop and watch this before you take tonight's dose. I'm about to show you something that runs against what a lot of patients are still being told every single day. And by the end of this, you'll understand your blood pressure in a way a rushed 10-minute appointment rarely has room to explain. I'm Dr. William. I work in emergency medicine, and after years of seeing exactly how these stories end, I can tell you with real confidence, the single most dangerous word in blood pressure care for adults over 65 might be the word perfect. Because for a lot of older adults, the number their doctor is celebrating on the chart can be doing quiet damage that doesn't show up until 3 a.m. when they stand up to use the bathroom and the room goes dark. Before we go further, drop your age in the comments. Nothing else needed, because what I'm about to explain applies very differently depending on whether you're 65, 75, or 85. And if you've ever felt dizzy or lightheaded standing up from a chair or getting out of bed, add dizzy too. You'll understand exactly why in a few minutes. Margaret's story. I want to tell you about a patient I'll call Margaret. She was 79 when her daughter first brought her in. Sharp, funny, still drove herself to church every Sunday. She'd been managing high blood pressure since her late 60s. One medication became 2, then 3. Every time, the goal was the same number, 120/80. Every time her pressure came down, the note in her chart read, well controlled. Margaret trusted the process. Then one morning, about 4 months after her pressure had finally settled at 122/76, Margaret stood up from her kitchen table, reached for her coffee cup, and the floor came up to meet her. She fractured her wrist catching herself. When paramedics checked her pressure lying on the kitchen floor, it read 118/74. Standing, it was 86/58, a 32-point drop the instant she became upright. Her brain hadn't been getting adequate blood flow every single time she stood for months. The dizziness she'd mentioned twice at appointments had been written off as age-related. Advice given? Rise slowly. No medication review, no further testing. Margaret's wrist healed. Margaret didn't fully bounce back. She became afraid of her own kitchen, stopped driving, and her world shrank to the distance between her bedroom and the sofa. 11 months later, reduced mobility led to a bout of pneumonia and a 9-day hospital stay. She survived, but she never drove herself to church again. Her daughter asked me afterward, how can a perfect blood pressure number do this to someone? That question is exactly why I'm making this video. If you felt the dizziness standing up, comment dizzy right now, because Margaret's story might be closer to yours than you realize. What the guidelines don't tell you. For decades, the message has been simple. Lower blood pressure equals better outcomes. 120/80 is the goal. Lower is safer. For adults in their 40s and 50s, that's broadly true, and it's advice I'd give without hesitation. But something genuinely changes in the cardiovascular system past 70, and a lot of the guidelines still in everyday use were built on research that was never designed to answer the question of what's actually safe for that older, more complicated body. I'm not going to hand you a target number just yet, because a number without the context behind it can do more harm than no number at all. You need to understand why a 75-year-old's body is physiologically different from a 55-year-old's first. What the research actually shows. In 2015, a landmark trial enrolled over 9,000 adults over 50, average age around 68. One group aimed for a systolic pressure below 120, a standard group aimed for below 140. The headlines were huge. Fewer heart attacks, fewer strokes, fewer cardiovascular deaths. Below 120 became the new rallying cry. Here's what the headlines rarely mentioned. That trial excluded anyone with diabetes, anyone with a prior stroke, anyone with dementia, anyone with advanced kidney disease, anyone with significant frailty. In other words, the study that set the target so many doctors still chase was tested only in the strongest, least medically complicated older adults available, not the average 78-year-old juggling 3 chronic conditions and 4 medications. Not Margaret. In many cases, not you. And the same trial documented meaningfully higher rates of dizziness, fainting, kidney complications, and falls requiring hospitalization in the intensive group. The cardiovascular benefit was real. So were the costs. A separate large trial out of China a few years later, looking at adults aged 60 to 80, found almost the same pattern. Better cardiovascular numbers in the lower target group, alongside more falls, more dizziness, more kidney strain. Years of clinical experience have taught me this. Those trials answered an important question, just not for the population sitting in most exam rooms every week. And the guidelines built from them have been applied broadly to patients who were specifically excluded from the data behind them. That gap between the research population and the real patient in front of you is exactly where Margaret fell. Literally. Why a body past 70 isn't a body at 50. 3 things change in the cardiovascular system with age that make this matter enormously. First, arterial stiffness. Picture a garden hose left coiled in a garage for 20 years versus a brand new one. The old one doesn't flex the way it used to. Arteries go through something similar. When the heart pumps into stiffer arteries, they can't absorb the pressure wave the way they did decades earlier. And the body needs a slightly higher baseline pressure to reliably get blood to the brain, especially standing upright against gravity. Second, baroreceptor sensitivity. Blood vessels contain tiny pressure sensors called baroreceptors. In a 30-year-old, they detect a drop the instant you stand and signal the heart within milliseconds. In a 75-year-old, those sensors have slowed down. If your baseline is already tightly controlled around 120 and your baroreceptors are sluggish, the drop on standing reaches the brain before the body has time to correct it. That's the room spinning. That's Margaret's kitchen floor. Third, medication metabolism. Kidneys and liver at 75 don't clear medications the way they did at 50. A dose calibrated perfectly 5 years ago may now be hitting harder and lasting longer, pushing pressure lower than a single office reading suggests. A seated reading of 122/76 can look ideal on a chart. What it can't show you is what happens to that number the moment someone stands up. The test you can do tonight. Here's something worth 3 minutes tonight. All you need is a home blood pressure monitor, available cheaply at most pharmacies. Lie flat for a full 5 minutes and rest completely. Check your blood pressure lying down and write it down. Then stand up immediately and check again right away. Don't wait. Write that down too. If your systolic, the top number, dropped more than 20 points, or your diastolic, the bottom number, dropped more than 10 points, that's orthostatic hypotension. Exactly what was happening to Margaret every morning for months before she fell. This is measurable, it's addressable, and it's often related to medication. Bring those numbers to your next appointment and don't accept that's probably just age as the final answer. This is a test most routine visits don't include, but you can run it yourself tonight. Comment TEST if you're going to try it. A framework, not a single number. Here's the framework I'd want a loved one to have, broken down by profile, not a one-size-fits-all target. If you're 60 to 74, active and independent, without major chronic conditions or multiple medications, a systolic target in the 125 to 135 range is reasonable and well supported for that profile. If you're 60 to 74 with diabetes, a prior stroke, several medications, or any pattern of dizziness on standing, chasing 120 isn't necessarily the right move. A target closer to 135 to 145 can offer meaningful cardiovascular protection without the fall risk that profile carries. More medication isn't automatically more protection. Sometimes it's more risk. If you're 75 to 84 and generally healthy, current evidence increasingly supports a range closer to 135 to 145 as associated with the best overall outcomes for that age group rather than 120. If you're 85 or older, or frail at any age, preventing falls often becomes a higher clinical priority than an aggressive number, and something closer to 140 to 150 systolic may genuinely be the safer zone for that physiology. I know that looks high next to every pamphlet in every waiting room, but we're not treating a pamphlet, we're treating a person. One number almost nobody talks about, the diastolic, the bottom number. For older adults, I want that comfortably above 65, ideally 70 to 85. Below 60, blood flow to the heart muscle itself during its relaxation phase can be compromised, even if the systolic number looks fine. If yours consistently sits below 60, that's a conversation worth having at the next visit. 2 patients, same number, different plans. Take 2 patients, both 72, both with a reading of 142/84. One golfs twice a week, no diabetes, no prior cardiac events, healthy kidney function, and feels completely well. His doctor wants to add a second medication to reach 120. My instinct there, leave it. The risk of pushing him into orthostatic territory outweighs the marginal benefit for his profile. The other patient, same exact reading, has type 2 diabetes, 1 prior cardiac event, and reduced kidney function. For her, 142/84 does carry real risk, but 120 isn't the right target either. Her kidney function and diabetes shape a different perfusion picture that an aggressive target could destabilize. Her sensible target sits closer to 130 to 135, reached gradually with orthostatic checks at every adjustment. Same number walking in, 2 very different plans walking out because you treat the person, not the number on the chart. That's what having a real number actually means in practice. What to bring to your own doctor. If your doctor already has a target set for you, I'm not suggesting you throw that out. I'm suggesting a more specific conversation. Bring a home blood pressure log, morning and evening, for 2 weeks. Bring your orthostatic test results from tonight. Bring a simple symptom list: dizziness on standing, unexplained fatigue, morning brain fog. On blood pressure medication, these aren't simply getting older. They may be your body telling you the chart number isn't the number your physiology actually needs. Ask directly. Given my age, my conditions, and my medications, is 120/80 really the right target for my body? A doctor who's current with the evidence will engage with that question, and the data you bring is what makes that conversation possible. Where Margaret is now. Margaret still comes in to see me twice a year. After her wrist healed, we reduced 2 of her 3 blood pressure medications. Her pressure settled at 138/78, and her orthostatic drop went from 32 points down to 11. 6 months later, she told me she'd started driving herself to church again. That's what the right number looks like, not the number on a guideline poster. The number that keeps someone in their own car on a Sunday morning. You now know something a rushed appointment rarely has time to cover. Blood pressure targets aren't universal. The landmark studies behind 120 excluded people like the patient actually sitting in most exam rooms. There are real physiological reasons an older body needs a different framework, and there's a simple test you can run tonight to find out where you stand. You're not a number on a chart. You're a person with a specific body, history, and set of risks that deserve a specific answer. Know your real number and make sure whoever is prescribing it actually knows you, not just your chart.